welcome to the Decera Clinical Education Infectious Diseases Podcast, formerly the Clinical Care Options Podcast. I'm your host, Kristen Formby. This episode features audio from our live webinar on the latest updates on HIV treatment and prevention from the 2025 IDWeek and EACS conferences. I'm joined by Dr. Karine Lacombe, Professor of Medicine at Sorbonne University in Paris, France, and Dr. Chloe Orkin, Professor of Infection Inequities and Dean for Healthcare Transformation at the Queen Mary University of London. To view the full educational program and to download the accompanying slides, please visit the show notes for this episode. Now, let's get started with Dr. Orkin.
So I'm going to start off with a study on salvage lenacapavir plus optimized backbone in heavily treatment-experienced people living with HIV. And we're talking about a group of 70 people in a retrospective cohort from 5 clinics in Chicago and 1 in Pittsburgh. And these people were followed up from 2020 to 2025, and they'd been on a mean time from diagnosis 24 years. So we can all imagine what people have experienced in this group. And you can see that more than half of them had viral loads more than 200, and a very small proportion, 4 of them, had viral loads more than 100,000 copies, with a median CD4 count of 271. And in terms of resistance to at least 2 agents in the class at Lenin initiation, what you see is that most people had NRTI and NNRTI resistance, and there were some people who also had INSTI resistance. And if we looked at the estimated number of active agents in the optimized backbone, half of them had greater than one drug or more, and 43% had greater than 2 drugs. So you can see that this is a pretty experienced population. And if we look at the outcomes in terms of maintaining new virological suppression in those people who came into the study with detectable viral loads, you can see that 82% maintained virological suppression and that 89% continued on lenacapavir after the study end. It's important to say that, as I said to you, only some proportion of these people had a viral load greater than 200 to start with. So for those that didn't, for those that were undetectable, there's no virological failure in people who had virological suppression at baseline. So all in all, people did very well on this cohort. And in terms of injection site reactions, a large proportion of people had none, with some people reporting mild to moderate injection site reactions. Interestingly, daily treatment burden decreased while the active antiretroviral agents increased when using the combination, and there was no reduction in the total number of distinct agents after initiating LEN. But obviously the limitations are it's a small study, inconsistent follow-up, and lots of variations around decision-making for the clinical care of these people. So then there were 2 other studies which are sort of going in 2 different directions. The first direction is off-CAB in the EMPOWER study, switching from LA cabalpivirine to bictegravir, FTC, and TAF. And you can see this is a very small study of 33 people who decided to switch off cabotegravir or pivirine, mainly due to reasons of side effects. And at 4 weeks after they switched, in 23 out of the 32 people who responded, they were experiencing no adverse events from bictegravir, FTC, and TAF, and they felt much happier in terms of their treatment satisfaction in this group of people who no longer wanted to be on injections. The other study is the Prefer LA study. This is also quite a small study of 160 people, a real-world study switching people from oral treatment to long-acting cabotegravir or pivirine. And the important thing about this cohort is that the clinicians didn't have access to the genotypes or the treatment. So there were sort of unknowns in terms of the background history of these people. And also, the primary reason that people wanted to switch to cabotegravir or pivirine was the self-reported suboptimal adherence. Also, the people had been on, a large proportion of these people had been on 2 or more regimens in the past, and also had exposure to integrase and NNRTIs in the past. So there was some potential possibility these people, may have had some, experiences on these drugs before. But none, despite all of this, 97.5% of the people who switched preferred cabotegravir or pivirine, and 98% of them who switched to cabotegravir or pivirine achieved or maintained viral suppression to less than 200 versus 89% at baseline. So you can see for this population with difficulties, it went well in this real-world study. Now, weight and metabolic outcomes continue to be of great interest to people, and there were some studies that were presented that looked at this specifically at EACS. The first one was the P052 study, and this is looking at switching, a double-blinded switch from bictegravir FTC and TAF to duravirine/islatravir. And there were multiple measures of body composition and a mean percent change in weight and lean mass and body mass and every possible imagination that you could look at, 5% weight gain, 10% weight gain. And no matter how you looked at the data, under any circumstances, the differences were very similar and minimal. And there was sort of around a third of a kilo difference between BF-TAF and duravirine/islatravir, no matter how you looked at it. One thing that I will say about this group of people is that 70% of them fell into the criteria for overweight or obese, and 90% had been on bictegravir FTC and TAF for at least a year. So that was the cohort. When we look at the DO-IT study, this isn't a study for people who met criteria for obesity, who switched from INSTI to duravirine with or without switching to TAF or TDF. And what we see in this study, who switched from INSTI to duravirine, there was no changes in triglycerides, cholesterol, insulin resistance, or total body fat at week 48. So switching to duravirine with or without switching TAF to TDF didn't change any of these parameters. And then there's another very interesting study called the Paso-Doble study, the big study, it's the biggest study so far evaluating switching to dolutegravir 3TC or bictegravir FTC and TAF. And as well as showing similar efficacy, no differences in efficacy, there was a signal for greater weight gain observed with bictegravir FTC and TAF. And this was statistically significant. So there was more weight gain with bictegravir FTC and TAF versus dolutegravir 3TC. Now, this was found at week 48, but the trend actually increased at week 96. So at week 48 was around a kilo, and by week 96, the difference was 1.5 kilos more weight gain in bictegravir FTC and TAF versus dolutegravir 3TC, sorry. So the next study I'm going to talk about is the Capri study, and this is an interesting study looking at long-acting cabotegravir or rilpivirine in people with very, very severe renal impairment, but they had to have been virally suppressed. It's a very small number of people, 12 adults, but it's a real data gap. And they all had stage 4 to 5 chronic kidney disease, and 6 of them were actually on hemodialysis. And what was found is that viral suppression was maintained. They were dosed monthly and initially, and the CD4 count maintained except for 2 people who received transplants. And the kidney function was stable and actually improved in the 3 people who received transplants. There were no significant adverse drug reactions. The most common adverse drug reactions were injection site reactions. There was no significant adverse effects of being on cabotegravir or rilpivirine, but there were the usual injection site reactions, and 1 person died due to an unrelated reason. So then this is a really interesting implementation science development. So this is the mobile delivery of long-acting cabotegravir to people living with HIV and adherence challenges. So it's called MORE, and it's a mobile outreach, retention, and engagement program. So it's really wraparound care at the Whitman Walker Health. And this was a target population of people who had detectable viral loads greater than 200, who hadn't had or no medical visit in 6 months. Okay, so these people either had disengaged from care with a detectable viral load or had a detectable viral load. And they had the option to receive cabotegravir or rilpivirine at home in privacy. And there were other support measures that were actually wrapped around. So for example, option for ride share to the clinic, having weekly meetings for team care planning. And what this study is evaluating is the feasibility, it's implementation science. So they're looking at feasibility, appropriateness, and acceptability. And these are measures that assess a new implementation and of a new intervention. And what you can see in terms of agreement for acceptability, feasibility, and appropriateness is that 77% felt that the MORE program was acceptable, 79% was feasible, and 65% was appropriate. And the home injections acceptability was 63%, feasibility 70%, and appropriateness 61%. So thinking about uptake of home injections, the willingness was 67%, and in the qualitative interviews, the reservations were around privacy, which doesn't surprise me because I've seen this in other studies, that really the biggest concern about home delivery is around who is coming. Is it an individual car or a mobile van? And what are people going to think? But basically, it was very positive. All this additional wraparound care was very well received, and investigators concluded that delivery of CAB or Piperine through the MOR or home injection is effective and appealing. So then there's been a lot of talk about the risk of reactivation after nucleotide withdrawal, and this is because none of the future two-drug therapies contain tenofovir products, and the existing two-drug therapies may or may not contain 3TC. So this was a very big prospective observational cohort of 741 people who switched to cabotegravir or Piperine in Barcelona between 2023 and 2025. And they had a group of people who were in a number of different serological patterns. Most people were vaccinated. So 454 were people who were S antigen negative, core antibody negative, and S antibody positive. But there were 165 people who were S antigen negative, anti-core positive, and anti-S antibody positive. And then there was 3% with isolated anti-core, and 4 people who actually qualified as having chronic HPV infection. But there were no reactivations or new infections in these people. And then the Swiss cohort did an analysis of 358 hepatitis B S antigen core antibody positive people who switched from tenofovir-based antiretroviral agents without HPV activity or XTC containing ART. And they found that HPV DNA or S antigen positive only occurred in 3.9% of participants after a year of switching away from tenofovir. So 2 studies evaluating this point. But I think the key point to say is that clearly routine monitoring, vaccination, and HPV screening is very, very important. In this study, this Barcelona study, they monitored them at baseline at week 12, week 28, and after that every 6 months. So that was their monitoring schedule. And they only did DNAs if there was abnormalities in LFTs. So moving to investigational treatments, I'll start with the EMBRACE study. And this is looking at every 4 months of either IV or subcutaneous N6LS, which is a bNAb, plus monthly cabotegravir. And it's a phase 2b study. People had to be virally suppressed with no contraindications. And they were randomized 2:2:1 to receive an IV version of N6LS plus CAB IM, or a subcutaneous version with CAB or oral standard of care treatment. And as I've said, it's a phase 2b study, so there were 50 participants in the investigational arms with 26 participants in the oral ART, and the endpoint was really looking at safety and tolerability. What was found is that IV N6LS was very well tolerated and with no serious treatment-related adverse events or discontinuation. There were no ISRs that resulted in discontinuation. There were no serious or severe immune events of any kind, and no significant lab abnormalities. And LA-CAB monthly dosing was safe and tolerable together with this drug. And both participants rated both IV and subcutaneous N6LS as highly tolerable. But because of the injection site reactions and the favorable efficacy, safety, and participant feedback, the drug that's going to be moving forward is a twice yearly IV N6LS plus cabotegravir every 2 months, rather than the subcutaneous form. So they're going to move forward with the IV option. And I'm now going to hand over to my wonderful colleague, Professor Karine Lacombe.
Hi, everybody. Very happy to be here with Chloe. The other investigational drug that we wanted to present to you is the twice yearly lenacapavir plus tetrapavilimab and zinlivimab, which are 2 broadly neutralizing antibodies. And what we've got here is the result, a long-term result, week 52 of a trial which has already presented in earlier conferences. So this is a multi-center, open-label, randomized phase 2 study. You see here the randomized 2:1 of lenacapavir plus tab and dab given every 6 months IV, and lenacapavir subcutaneous, compared to a stable oral baseline regimen. All the patients were suppressed at baseline for more than 12 months, and they were on stable oral ART. And very important to note, they had all viral susceptibility to TAB and ZAB. And they were HBV negative because, we didn't want to see any HBV reactivation in that trial. The primary endpoint was at week 26, but here at the conference, the EACS conference, we presented the week 52 secondary outcomes like HIV RNA, under or above the threshold, and the safety and CD4 cell count change from baseline. So here are the results. So 53 people were randomized to len-tab-zab, and 27 stayed on stable oral ART. So you see that 3 people, which means 6% on len-tab-zab, had a confirmed virological rebound. 1 case with a resistance to len, 1 case resistance to zab, and 1 had a lower level of viremia, and all resuppressed on oral ART. No difference regarding the CD4 T cell count in both regimen. And regarding the preference, 76% of the patients randomized in len-tab-zab said that they preferred that regimen compared to a daily oral ART. You have to remember that len-tab-zab have been given intravenously every 6 months. So, and regarding the safety, no safety events to be recorded. This is pretty good and comforting result regarding this new therapeutics, although we are still questioning the feasibility on a large population due to the necessity of looking for susceptibility to TAB and ZAB. So the next investigational agent that I would like to share the results with you are the once weekly islatravir and lenacapavir oral pills. So this is one of the newest long-acting strategy which is developed. So you have here the study design. That's an open-label, active control randomized phase 2 trial. Here again, we already know the week 48 set result, which has been presented in former conferences. And here, for the current analysis, the endpoints were at week 96. So again, the efficacy, virological efficacy, but also adverse events, CD4 cell count changes, adherence, and change in BMI and body weight. And just to remind you about the design, so the patients were stable on the big TAF FTC regimen. They were undetectable at randomization, and they were randomized in 2 arms, either continuing big TAF FTC QD or randomized in islatravir 2 milligrams. So the 2 milligram dosage was chosen to avoid dose-dependent changes in CD4 cell count and lymphocyte count. And islatravir 2 milligram was associated with lenacapavir 300 milligram oral once per week. So you see here the results. So the week 96 outcomes. All the patients were totally suppressed, so very important and nice results. No emergent islatravir lenacapavir resistance detected through week 96, and the mean adherence by pill count was exceptional, almost reaching 100%. No drug-related adverse events and no difference in adverse events in the 2 groups. No impact on the CD4 change, which was really reassuring given what we knew with earlier trials using islatravir. That's why phase 3 trials are going on, Ireland 1 and Ireland 2, with the fixed dose islatravir and lenacapavir. Okay, so a few takeaways of that investigational drug section. So treatment satisfaction is high after switching ART, as you have seen from all those studies, and we didn't see any changes in weight or metabolic parameter after switch to doravirine-based regimens. It was one of the biggest questions over the years since we had access to doravirine, and even less weight gain with dolutegravir 3-TC compared to the tegravir FTC TAF. Very big topic at EACS, the risk of HBV reactivation. So we were pretty happy to see quite good range of studies showing that there was a really low HBV reactivation risk when switching ART, especially when getting rid of FTC, 3TC, TDF, or TAF. The mobile delivery of LA-CAB and rilpivirine has shown that it's feasible and acceptable to people living with HIV, and that was very nice study that Chloe has shown to you. On top of that, LA-CAB and rilpivirine were effective and safe in those with severe renal impairment, and this is a very nice news to have such an option for our patients with the renal kidney disease. And some more data regarding newer investigational agent and especially the new class of neutralizing antibodies and N6LS plus LA-CAB and twice yearly lenacapavir and Tab/Zav, but also weekly oral islatravir lenacapavir were really tolerable with a promising efficacy. Some of those associations going now in phase 3. And I will now start the last section with the HIV prevention strategies. So first of all, some new data about the Purpose 2 trial. So you have seen very nice data in earlier conferences this year. This one is a sub-analysis about persistence. So the annual persistence of twice yearly subcutaneous lenacapavir versus daily oral FTC TDF as PrEP. So the Purpose 2, just to remind you, this is an international double-blind randomized phase 3 trial in more than 3,000 cisgender men, transgender women, transgender men, and gender non-binary people aged over 16 years. In the previous report, the HIV incidence with the twice-yearly subcutaneous LEN was significantly lower versus the background HIV incidence. And you see here the ratio, which is 0.04, which means almost no infections in the group taking lenacapavir compared to daily oral FTC TDF. So very, very interesting results, which really support the fact that lenacapavir as PrEP is a real breakthrough intervention that we can offer to the participants now. And this is very good news for everybody. But here at that conference, in EACS conference, we have focused on the annual persistence of the twice yearly subcutaneous LEN versus the daily oral pill. And this is a random pre-selected 10% of people analysis of people taking more than 1 year of the drugs. And here you see the very reassuring data regarding the persistence on the LEN, which is 63.6% compared to 37.3% with oral FTC TDF. So the adherence to LEN and placebo injections were more than 92% through week 52, with a waning of oral PrEP adherence, which means more than 4 doses. So it's not even 1 dose per day, it's 4 doses per week. So it waned from 82% at week 8 to 62% at week 52. So the use of lenacapavir was associated with a higher and significantly higher annual persistence versus daily oral FTC TDF. And when we look at the non-persistence observed in the 36 people on the LEN and 32 people receiving FTC TDF, so for the people on LEN, 21 of them missed week 26 injection, 14 missed on time week 52 visit, and 1 had a late week 26 injection. But when we look at FTC TDF, 18 had more than 1 missing DBS sample, and 14 had more than 1 DBS concentration indicative of non-adherence in prior 8 to 12 week period. So it really supports the use of LEN, and I hope that the deployment of LEN will be available in many countries now that we have seen the higher efficacy, but also a higher annual persistence. which supports deployment on a very large scale of a strategy of PrEP based on lenacapavir. If we still stay on this sub-analysis, but look for in this very specific analysis among people who use substances, and especially the binge drinking, the drug use, the stimulant use, opioid use, and injection drug use, that sub-study was analyzing the adverse events in that category of persons with a substance, with the use of substances, a diverse range of substances. We didn't see any higher rate of adverse events, so really similar. Same for injection site reactions. No substance use overdose, and the most common adverse events included chlamydia, gonococcal, and upper respiratory infections, which was very similar in all groups, either using substances or not using substances. And also very reassuring, the lenacapavir adherence was similar in all groups. And also very important in that sub-study, the modeling of PK/PD suggest that there was no significant lenacapavir fentanyl interactions. So here again, very reassuring data in every groups of people in need of lenacapavir, in need of PrEP. So again, supporting the deployment at a large scale of lenacapavir as a PrEP drug. Another sub-analysis regarding the gender-affirming lenacapavir PrEP in coadministration with gender-affirming therapy. So about 253 people, which is around 12% of all included people, participants, they received more than one gender-affirming therapy. And we saw in that sub-study of pharmacology no significant impact on lenacapavir on concentrations of gender-affirming therapy. And it could be either with serum estradiol or plasma testosterone or DHT concentration, and they were very comparable between baseline and lenacapavir. So again, it adds on all the corpus of knowledge we have with the use of lenacapavir as PrEP. So if we switch now to another combination, another strategy, for PrEP, cabotegravir versus lenacapavir. So this Clarity trial was very interesting because this is a crossover study in healthy adults. So it's not a study in HIV infected patients. So just remember that, because it's important to understand the design and the objective of that trial. So those participants included were all adults without HIV, with a BMI between 18 and 32. And the participants with comorbidities, infections, and substance use were excluded. So a number of 64 were randomized either to get cabotegravir given every 2 months intramuscular, or lenacapavir given every 6 months subcutaneously. But we saw an acute observation phase with day 8 assessment. And then the next dose were either lenacapavir in the people having got CAB at the beginning, or CAB in people having got lenacapavir at the beginning. And then we had a follow-up phase. The primary endpoint was a participant assessed local reaction acceptability 7 days post-injection via this questionnaire administered through a PIN device. And the secondary endpoints were the injection site reaction incidence, severity, duration, and the preference of healthcare providers. So you see that this is really a study focusing on safety, tolerability, and preference of the healthcare providers. So what did we see? Some interesting results. Lenacapavir was associated with more frequent and visible injection site reactions versus cabotegravir. So you see here the non-pain ISRs was 100% lenacapavir versus 49% with cabotegravir, and the ISR graded more than 2 was 57 lenacapavir in lenacapavir versus 37 in cabotegravir. So cabotegravir was associated with lower initial pain scores versus lenacapavir, but it was similar on day 3, 5, and 8, with a peak pain in cabotegravir higher, 2.4, than in lower, in cabotegravir, 2.4, compared to 3.3 in lenacapavir. And most of the HCPs which were surveyed preferred cabotegravir to lenacapavir due to the fewer and less adverse events and less pain during the injections. So their own feeling regarding what they saw in their patients. So I think that this is something very important to take into account when you will use either lenacapavir or cabotegravir as PrEP in the participants, and at least it can really inform, it will be very important to get informed data to the participants. So when they will be able to choose between cabotegravir or lenacapavir, they're going to have everything in hand to choose the drug which is the best for them, so you can keep them on that drug for the long term. So a few takeaways regarding prevention. To remind you that in Purpose 2, in all the sub-analysis I've been showing you, we saw a higher annual persistence with a twice-yearly LEN PrEP versus daily oral PrEP, with a similar adherence and safety in people who did or did not use substances. So this is very important data, so we can offer that strategies in all groups, and especially the more fragile and vulnerable ones. And we saw that we had no interaction between LEN and gender-affirming hormones. And in this small clarity study, the local reaction rate is as totally or very acceptable. We're seeing in 69% of those receiving cabotegravir versus 48% receiving LEN, with more frequent and visible injection site reaction with lenacapavir versus cabotegravir, where also more HCPs preferred cabotegravir to LEN due to fewer adverse events and reduced pain. And then we'll turn to the Q&A session.
Yeah. So, Karine, I think why don't I start with the question, which is about the Capri study. So someone has asked about whether in the study for people with renal impairment on cabotegravir, was the drug given both monthly and 2 monthly, and was there any difference? So just to say that the study was 48 weeks long, and for the first half of the study, people received it 1 monthly, and then for the second half, they received 2 monthly, and they did PK measurements to measure the drug levels, and there was no difference whether people received it 1 monthly or 2 monthly. So that's good news for that issue. And then there was a question about hepatitis B reactivation. Did any participant require HBV treatment after withdrawal of the tenofovir-based regimen, any hospitalization or deaths? So, Karine, I don't know if you wanted to talk about that, or I could chime in. What would you?
I can answer those questions. Of course, this is why we were very anxious about getting results about possible HBV reactivation in people going on NUC sparing regimen, based on tenofovir, TAF, lamivudine, or FTC. And so you have to you have to keep in mind that in those studies we have presented to you, some of the people had anti-HBs antibodies. So not all were anti-HBC antibodies, isolated anti-HBC antibodies. But what we saw is that in the first study from the hospital clinic, they didn't see any HBV reactivation, so absolutely no problem with hospitalization or death related to HBV reactivation. In the Swiss cohort, they have seen reactivation, but none had led to hospitalization or death. And some of the reactivations were diagnosed only because the patients experienced some mild flares, not more than 2 times upper limit of transaminases. And some of them were put back on tenofovir, but we didn't see any big HBV reactivation as we may see when people are put on targeted therapy such as rituximab, for example. So the mechanism of reactivation is totally different. And I think that we may be quite reassured. During the session on HBV reactivation, we discussed a lot and at length about how often we should monitor the patients, and nobody was really agreed on the rhythm of the follow-up. So people said that transaminases should be checked every 3 months at the beginning, probably not associated with HBV DNA every time for cost issue in some countries, but you could do HBV DNA every 6 months.
So I think I can't imagine that there could be any questions left after that really comprehensive answer to that question. And then I think there's another question which I'd be happy to take, which was about purpose 2. And was there any ongoing assessment of sexual risk behavior through the course of the trial? Some participants could have decreased or increased their risk behaviors apart from drug use. And I think just to say that, firstly, STIs were tested for all the way through the study. And, going throughout the study, everything that's been reported so far suggests that STIs continue throughout the study, and that these were people, who were very much in need of PrEP. And of course, if there were changes, they could happen on either arm, and that's why it's a randomized study.
Thank you to our expert faculty, and many thanks to you, our listeners, for joining us. To view the full conference coverage program and to download the accompanying slides, please click the link in the show notes. To get access to all of our new podcasts, subscribe to the Decera Clinical Education Infectious Diseases podcast, wherever you get your podcasts. Thank you and have a great day.